Thank you, Tahir, for joining us today. So can you please come and start your presentation?
Assalamu alaikum, everyone. Just want to see if I can change the slides myself. Brilliant. My name is Tahir. I'm one of the ST3 registrars in orthopedics, and I'm working in West Midlands, but also in the last 3 years I've been working as a digital PGVLE fellow for the PGVLE. Hopefully most of you have heard of it. Not that many people here, but anyway, hopefully. So when COVID started in 2020, for the core surgical training, for the core surgical trainees, you can imagine the face-to-face teaching was cancelled. So I was working with a consultant at the time who was trying to make sure that we could meet the curriculum of the core surgical trainees. But along with that, because they were cancelled, we had to teach them. So initially, the initial aim of PGVLE was that we could get at least the West Midlands core surgical trainees a teaching platform. So the necessity is the mother of invention, so we came up with the PGVLE. So the PGVLE is a website, and the main aims of it were that we wanted to make sure that there was a virtual classroom, which is interactive, but along with that as well, we needed to make sure that it had a lot of user contribution as well. We didn't want to make sure because there were just 3 people. It was Mr. Ahmed, the trauma and orthopedic consultant. He was in Telford first, and now he's in Worcester. I was a CT2 then, and then we had an ST3 registrar in vascular. So in between us, we were able to come up with a very good idea of making sure to continue medical education, and we didn't want anyone to be suffering from the COVID more than everyone was. So initially, it was started for the core surgical trainees. So it included monthly teachings, webinars, but because of the amazing feedback that we got from it, we were able to pitch it to the HEE at that time, but now it's rebranded at NHS England, and they were able to take it up. So it became a very good way of making sure that we continue the medical education that was going on. So because it was so successful in core surgical training for the West Midlands, HEE thought that we could expand, and that's what we did. As you can see from the amount of specialties that we have, there is GP training, foundation, every specialty known to man. But also along with that as well, we wanted to make sure that there were quite a lot of developmental courses, as you can imagine, for surgical tutors, medical tutors, and along with that, educational supervisors as well. And that's we were able to incorporate that. But I think the best part about this was we were able to expand on the digital teaching fellow role. We got digital teaching fellows from every specialty, and we empowered them to make sure that they could do anything they wanted with the teaching sessions. If they wanted to make it interactive as possible, they could do that. If they didn't want to do that, or if they want to go another direction, they could do that. But I think one of the most important things that we brought was we went through quite a lot of softwares. Microsoft Teams, Zoom, we didn't like any of those. So we had an in-house big blue button that we incorporated to ensure that there was more interactability between the trainer and the trainee, and also everyone was awake during virtual teaching. I've been known to sleep through most of them. But now, initially it was started for 300, but now I'm proud to say that we have more than 16,000 users on the PGVLE. And we don't have just the West Midlands. We've expanded to Thames, we've expanded to Southwest, and we've expanded to the Eastern Midlands as well. And as you can see, there's quite a lot of new people that are getting involved. There's dentistry, GP, and foundation. So a lot of people have seen the potential of what PGVLE can be or could be, and they've taken them on board as well. I think it's very monotonous to just say PGVLE is just for teaching, because medical education, as we all know, is not just pure teaching. You have to make sure they go through high fidelity simulation, especially for surgical specialties or acute medical specialties. So we were able to come up, and one of my basic positions and responsibilities are to come up with courses which are high fidelity on the PGVLE and face-to-face as well. So the 2 courses that you could see on the far left on the top, the CABC as well as the basic fracture fixation, I was able to come up with that. We came up with a design, we implemented it, and it was extremely, extremely successful. But along with that, as always, we were able to accommodate other colleagues who took up the mantle. So there are vascular courses, and these are not just for the West Midlands. They've started to grow to national as well. But I think the most important part is, how do you make these courses on a boring laptop screen interactable. So we went through quite a lot of softwares, again, quite a lot of long nights, quite a lot of mistakes, and then we were able to come up with software packages such as H5P and SCORM. And incorporating that into the PGVLE was one of the successes of the courses that we were able to run. The CABC course and the basic fracture fixation have gone through their third courses in the last 2 to 3 years, and we've had nothing but positive feedback. As you can see, all smiles around. But then, along with that as well, as we know, it's not just about courses and boring lectures that you cannot assess if they're being intractable as well. We came up with resources that you could actually put up on PGVLE. So we partnered with a software called as Primal Anatomy, and as you all know, surgery is nothing but anatomy, and you have to know them, just like the back of your hand, no pun intended. So what we did was we incorporated Primal Anatomy, which is a virtual reality anatomy teaching in the PGVLE. So every surgical specialty has free access to this, and all they have to do is go through PGVLE and just click a button and they can go there. But then, what's the future goal? Why am I here talking about PGVLE when I think there's been so many medical virtual platforms that you could use? I feel we were able to come up with, from its conception till now, not just a local teaching resource and a platform, but also we've actually incorporated this nationally as well. So speaking just from today, almost a year now, we've incorporated something known as the CST Hub, which is a monthly CST teaching for all of the core surgical trainees in the UK. And that happens, that accommodates around 1,200 to 1,500 people every month that they come. But along with that, we have now international national courses. We've actually had more meetings now that happen through PGVLE because it's so easy to access, obviously after the first time you've gone through it. But then along with that as well, I think the most important thing we were able to incorporate is not just about trainees. Medical education is for everyone. So we've incorporated not just international medical graduates, but also along with that SAS doctors who are going towards CSER training. And most of them have given us positive feedback. But you have to realize not all of it is done by the initial 3 or the team that we have. We've actually been able to incorporate other fellows that have come on board, given them the recognition and the autonomy, and they have come up with these courses. So it was started by Mr. Ahmed and myself and Alex. However, this has now gone even beyond, and we're coming up with more ideas of trying to make sure we can improve medical education. Any questions?
Thank you so much, Khalid. I believe that people have understood you very well.
Fingers crossed.
I must say that I have encountered as a college tutor with Dr. Usman.
Yes.
Yes. And I had full use of these resources, and I must encourage all of you. Need any further information, please contact me, and they will let you know how they guide you. Thank you so much.
No, thank you very much. Thank you.
Once again, Assalamu alaikum everyone. I'm Dr. Habib Haider. I'm the consultant acute medicine and RCP college tutor. I have my colleague from education team from APPNE, Dr. Samreen Muzaffar.
Assalamu alaikum, I'm Samreen Muzaffar. I'm a GP based in East Riding of Yorkshire. We welcome you all over here.
Thank you so much, guys, for coming here for APPNE 4th Annual Health Convention. We started our CME already with an excellent talk on virtual learning platform by Dr. Tahir Khalik. And now we have some of the panelists here. We have Mr. Naseem Waraich, who's a consultant surgeon at Walsall Manor Hospital and senior academy tutor, University of Birmingham. He also founding member of APPNE and also current executive member of the APPNE. We have Professor Zafar, who also is executive member of APPNE, and he also has done, sorry, 2 seconds. He's a director of public health and medical director in the NHS. He is a visiting professor of public health in 3 institutions. And we have third panelist. I mean, you come on to read out, Dr. Shamim Rose.
So Dr. Shamim Rose, and she was born in Pakistan and then grew up in UK and attended the University of Liverpool. She graduated in 1990. She has 32 years experience of being a medical practitioner and have been a surgeon, GP appraiser, been a forensic medical examiner, and aesthetic practitioner. She also completed 10 years as a governing body GP for Liverpool Clinical Commission Group. And she's currently a GP in Liverpool and also medical legal expert witness.
Excellent. And we have Dr. Najib Ahmed. He's a consultant radiologist, clinical lead at Hull University Teaching Hospital, and FRCR examiner at Royal College of Radiology. So, and we have Dr. Riaz, who's a consultant emergency medicine. So I will start first presenter, Dr. Zain Rana. Can I have the first slide, please?
Assalamu alaikum. Hello, my name is Dr. Zainul Abidin. I'm one of the clinical fellows currently working in cardiology department of St. Thomas's Hospital, and today I'm here to present a poster which I made about the quality improvement project that I started when I was working in the emergency department. So this is a quality improvement project about safe procedural sedation in the emergency department that I did with my colleagues. So in this presentation, first of all, I'll talk about the background, and then I'll talk about the aims that we had for this QIP, the methods we used, and then there was some, we compared the data, and then we found some results, and then we agreed on some things that we can implement in the future. So, so safe administration of sedation drugs like ketamine and propofol, which we commonly use in the emergency department to induce sleep or calm before procedures like reduction of fractures, is of paramount importance and carries many adverse effects if it is not undertaken correctly. So as sedation is not a life-saving procedure, so safety during this procedure is of utmost importance and should be done in according to the APPNE guidelines, which include pre-procedural assessment, minimum staff requirement, and monitoring of vitals during the procedure and the post-procedure assessment as well. So our aim during this QIP was to improve performance in annual audit as per ARCM standards for procedural sedations published in 2017-18 by improving compliance with the single document performer and maintain improvement of electronic sedation of the patients at discharge. So about the data, we collected data for the months May to July 2022 for the first cycle. And the number of cases that we identified were 11, 4 were in May, 4 in June, and 3 in July of 2012. And the sources that we used was Symphony, which is the electronic system that we use in the ED, the scan notes, the CD logbooks, and the sedation logbook. So when we compared this data with the data which was present from 2021, so we found improvements in pre-procedural sedational assessment, presence of team members, monitoring oxygen, and the discharge coding. 100% compliance maintained for documenting recess as an area of sedation. But there were some things in which we found there was lacking. So the consent and capacity documentation that had a decline from 76 to 72%, and the coding that also declined from 96 to 82%, and the 3-part documentation that didn't happen in any of the cases. As you can see in the graph, there were no cases which were documented on all the 3. Some of them were coded only electronically, and some of them only had on the CD book. So after collecting this data, the team agreed on implementing some changes so that when we collect the data in the second cycle that we are currently doing, so that we can improve the performance. So the main thing was to reinforce mandatory compliance of ARCM standards via a weekly key 3 to all the clinical staff members before the morning handover in the ED. We also sent emails to all the staff so that we can improve improve the knowledge about the standards. And then we informed the new starters during their induction lectures about this 3-point documentation. We also did some nursing teaching. We also currently running a sedation course in which we tell the newcomers about this procedure, and we have also posted some posters in the resource so that people are aware of these things. And currently we are collecting data for the second cycle, and then we'll see how these changes have implemented. Thank you so much.
Thank you so much. Any question from the audience? Thanks, Anurag. I've got one question to ask you. Yeah. What sort of procedures have you performed there in A&E where you use these sedation?
Yes. So procedure sedation is basically when we have a fracture of any fracture and we are doing the reduction. So induce the sedation, we use some drugs like propofol and ketamine. So these are the drugs that we use, and there are some things that need to be done before, and there is an ARCM guidelines about this. So this audit was about implementing and checking if we are following those guidelines or not.
So you just see shoulder reductions and anything else?
Yes, so in this we include any fractures or any other procedures which required the sedation before that.
Okay. And any adverse events have you recorded?
Yes, so the data that we collected in which we didn't find any adverse effect, but the possible side effects and the adverse effect regarding these could include respiratory depression with the sedation. There could be some nausea, vomiting, or there could be aspiration of contents as well.
Right. If my colleague wants to ask anything.
Yes, I just want to thank you very much for the presentation. Can you just give us a feel for how many patients in total go through the system in your hospital with this type of
yes.
care?
So we collected the data. The first cycle was for the 3 months. It was during May, June, and July of 2022. So during that time, we found 10 cases. There was an exclusion criteria as well. So the patients who were intubated, those were not included. Only the patients who had sedation for some procedure, those were only done. So we found 10 cases there. And currently, the second cycle, we are doing it now. So the second cycle is lifetime data, so we are collecting the data at this moment after implementing the changes.
Thank you.
Thank you, guys.
Thank you, Zain, for an excellent presentation. And thank you that you kept the time exactly 5 minutes. So thank you for doing that. Our next poster presenter is Dr. Zaina Sindhu. Can you put the next one, please? Oh, yes, thank you.
Okay. Hello, everyone. So my name is Zaina. I'm a final year medical student, and today I'm going to discuss a rare case of a urinary bladder paraganglioma I saw whilst on my urology placement. So as a bit of background, extraadrenal pheochromocytomas are known as paragangliomas. Paragangliomas of the urinary bladder are catecholamine-secreting chromaffin tissues. Most adrenal tumors manifest intra-abdominally along the sympathetic chain. Therefore, the prevalence of bladder paragangliomas are extremely rare. They account for less than 1% of all paragangliomas and less than 0.06% of all bladder tumors. Therefore, the aim of my report and this presentation is to provide clinical exposure of this rare tumor to reduce chances of misdiagnosis. So regarding the patient we saw, it was a 35-year-old female who was referred in by her GP, who presented with a 6-month history of cramping-like pelvic pain, dysuria, dyspareunia, in addition to palpitations and nausea associated with the full bladder. She also experienced 2 occasions of pre-syncope symptoms during micturition. Her history was negative for sweating, headache, and gross hematuria, and there was no other significant past medical or family history. Examination in clinic was unremarkable, with a blood pressure of 112/71, and initial investigations, such as urine tests and culture, revealed no abnormal findings, and blood tests as well showed no abnormal pathology. In terms of her imaging, she first underwent an abdominal ultrasound, which you can see in figure 1. This showed a 20 by 20 millimeter hypoechoic lesion on the left lateral bladder wall with peripheral vascularity. Following this, cystoscopy was done to get direct visualization of the tumor and to exclude other mucosal lesions. Figure 2 shows the results. This showed an extramucosal bulge near the bladder neck. And then an MRI was sought, which you can see in figure 3. This showed a 1.9 by 1.7 centimeter submucosal lesion. And following this, a provisional diagnosis of a leiomyoma was made. One, because that also radiologically appears similar, and epidemiologically wise, it is the most common benign bladder neoplasm. However, her images was discussed in MDT, and a biopsy was sought via transvaginal ultrasound. Histology showed smooth muscle and fibrostroma organized in a nested architecture and risk vascular network, otherwise known as a Zell-Ballen pattern, which you can see in figure 4. And immunohistochemistry showed cells were strongly positive for neuroendocrine markers, synaptophysin, chromogranin, and CD56. These were all diagnostic for paragangliomas, and therefore this diagnosis was made. The patient, in terms of management, underwent a partial cystectomy, and she remained, she had their follow-up afterwards with flexible cystoscopy, and there was no reoccurrence there. In terms of, lastly, with discussion points, so for patients with paragangliomas, initial investigations should involve measuring catecholamine levels, genetic testing, and imaging that I mentioned before. Regarding genetic testing, this is only offered for patients who are under 50 years old with a positive family history or patients with bilateral or multifocal disease. In terms of definitive diagnosis, immunohistochemistry should be done. Regarding treatment, options include catecholamine blockade, chemotherapy, and radiotherapy. However, surgical resection is first line, either through partial cystectomy or transurethral resection of bladder tumors. Partial cystectomy is preferred as other methods risk causing a hypertensive crisis. Figure 5 shows how this would work. When pressure within the bladder increases through contraction, through filling of urine, instrumentation during surgery or imaging, this applies pressure on the tumor, which would result in the release of the catecholamines, noradrenaline, and adrenaline, resulting in a hypertensive crisis, which increases risk of things like stroke and MI. Therefore, this point is important to know before doing any any procedures on these patients. And lastly, surveillance should be done following surgery. Post-operatively, we should look for clear margins, and if they are margin-free, you would do annual cystoscopy and measuring catecholamine levels to make sure there's no recurrence. Thank you.
Thank you so much, Zania. The floor open for questions, please. Anybody else? Yes, Sir Ahmed, Shabi Ahmed. You got mic? Yeah.
So it was a transvaginal ultrasound, and then did a biopsy through that. So with procedures like that, that increases the risk of tumor manipulation, and studies have shown that that increases the risk of hypertensive crisis. So for that reason, they prefer doing partial cystectomy.
Thank you. Anybody else? Yes, please.
I'll just
Well, one, it's very rare because typically, I said, it presents intra-abdominally, so the location of it is very rare with few reports. as well as her symptoms. Normally we get symptoms of hypertension or like hypertensive crisis. However, this patient didn't have that. She didn't have any hematuria as well, which was quite common. So initially, if those symptoms had presented, you would have gone along the lines of a pheochromocytoma or paraganglioma. But as she didn't, the initial diagnosis was a leiomyoma. So this is just showing how it can present differently.
Can I just add, thank you very much for that was a very good presentation. It's a very atypical case. Did the team consider, paragangliomas are associated with quite a lot of syndromes, which, with additional cancer. So did you consider doing surveillance imaging of the body or familial history? Because I think it will be important to screen for atypical cancer-inducing syndromes in this particular case. I mean, I guess that if you keep tabs of catecholamines, that's one way, but it will be helpful, perhaps. I don't know whether you agree or not, or whether that was performed, but that is something which you may consider, basically, in addition to what has been already done. Thank you.
Thanks. Yes, I think those things can be performed. In this case, it wasn't for the patient. I think she didn't have any kind of history, family history of it. I think for these patients, they could do genetic testing, but as I said, under NICE guidelines, she didn't really qualify for having that done. So, yeah.
Thank you very much. I'd just like to know, did you get any information from genetics departments for this study?
No, there was no genetic testing.
Just following on from my colleague's question about the family history and stuff, because it's actually a really interesting case. I haven't come across one
I think it's
presented before.
Yeah, for her to have genetic testing, she had to be 50 with a positive family history, and she had no family history of it. So for that reason, they didn't do any genetic testing.
Okay, thank you.
Yeah. Right, just one question from my side. What preoperative measures have you undertaken to have a safe space?
Sorry, could you?
What preoperative measures were taken before the surgery to have a safe surgery for this patient?
One way of reducing the risk of hypertensive crisis is preoperative alpha blockade. So if you give that to the patient preoperatively, that should help reduce it, but also close observation on the patient during the surgery as well. Thank you.
Okay, thank you.
Thank you so much, Zaina, and that was wonderful. Our next speaker is Arham Kokar, so if you can please come to the stage. Thank you.
Hello. My name is Arham. I'm one of the junior doctors in urology at Oxford University Hospitals. Today I'm going to present a closed-loop audit about increasing adherence to metabolic evaluation protocols in urolithiasis patients. I did this audit under supervision of my consultant, Ms. Sarah Howells. Renal stones are quite common in UK population. About 9% of the patients present with renal colic pains, and about 5% of the stone formers, they've got underlying pathology, underlying hyperparathyroidism going on that can be treated if picked out initially. So the NICE guidelines says that for all patients that come with renal stones or kidney stones or ureteric stones, they should have their calcium levels done. Calcium level is a cheap test that the NHS can do, and it helps you to pick out patients with metabolic disorders such as hyperparathyroidism. So my audit was on that, and the main objectives was to investigate and improve the adherence to calcium testing protocols, thereby facilitating the detection of treatable metabolic abnormalities within the OUH NHS trust. So what method did we use? Were during our first cycle, we took the data for the month of March and we compared it with the NICE guidelines. I've added the exact NG 118-2019 guidelines. You can search it up. It clearly says that the calcium levels must be done for all kidney patients, all kidney stone patients. So during our first cycle, we had a total number of patients of 54 who went to the lithotripsy department of OUH NHS Trust. So we took the data, we arranged it accordingly to the demographics, the initial presentation complaints, where the patient was seen initially, was it a referred patient or was it seen in our urology outpatients, what kind of treatment did it got, and other than calcium, what about the urate levels, what about the urine dipstick levels, were they done or weren't they done? The inclusion criteria for the calcium, we set that a serum or an ionized calcium levels within the 6 months of presentation, we included those levels. So we calculated, we collected the data, we did the intervention, the improvement bit. The improvement bit included of first that we did a teaching of all the urology consultants, the registrars, the SHOs, the emergency department who were referring the patients, and we sent an email to the local GPs as well in the OUH to assure this, the referral system. The second thing, the referral form, we changed the referral form a bit, and we can't make it compulsory for everyone to include calcium levels, but we wrote it down in bold letters that calcium levels must be done for stone patients while the patients were being referred to the lithotripsy pathway. The third most important bit that we did regarding improvement was that whenever the patient comes for lithotripsy, the lithotripsy nurses have got a whole flow chart of different observations and blood levels. So we included a column for calcium levels at that level. So whenever the patient comes, the nurses would check if the calcium levels are being done or if they are increasing if they are hypercalcemic or not. So any calcium levels that aren't being done or they are abnormal, they are referred to the urology on-call department to get them done or to get them sorted out or to get them referred to the concerned authorities or to the concerned medical departments. So we did that, and after that we closed the loop for the month of for 4th of September to 4th of October this year. And I've got this in front of me in the form of pie charts as well. So I'm just going to go in a bit of more details regarding the results. So out of those 54 the first cycle patients, a huge staggering amount, like 33% of the patients did not have the calcium levels done at any stage. And I'm not proud to say that, but out of those 33%, 72% of the patients were referred from the urology department, from the urology outpatients department. 11% were referred to the lithotripsy by the triage or the ward services, 11% from the MDT meetings, and only 6% from the emergency department. So emergency was quite good in doing calcium levels. So after the implementations, after the improvements that we did, we re-audited for the month of 4th of September to 4th of October. And due to the points that we implemented, we saw a compliance rate, like an improvement in the compliance rate from 67% to 87.2%, showing a notable 20.2% improvement. And in addition, we got 4.4% of the patients presenting with hypercalcemia, and we referred them to the medics for further testing. My second cycle included of 78 patients, and that 78 patients, out of them, as I told you, only 10 patients didn't have the calcium levels. And currently, even those 10 patients are being called back to just have an outpatient calcium or a bone corset being done so that they are also covered. So beside from the calcium levels, I also saw the urate levels and the urine dipsticks. Now, the NICE guidelines also says that for every patient coming in for lithotripsy, the urine dipstick should be done, and there's no purpose of doing urate levels. I didn't present the data for that because we had an excellent compliance regarding that. We have more than 95% of the patients following those guidelines. So to conclude my audit, I think the early diagnosis of metabolic disorders in frequent stone formers improves patient care, quality of life. It reduces the burden of NHS. It reduces the burden of the lithotripsy department, the lithotripsy nurses, and it helps evolve NHS overall. And through this audit, we have just shown that a simple educating measures and integrating mandatory testing in the nursing workflow charts can drastically improve compliance with the NICE guidelines and improve patient care. Thank you. Any questions?
All right. Any questions from the audience? Yes, please.
Yes, yes. So 5%. It's an Oxford study done by my professors and consultants that showed that calcium levels for like 5% of the stone formers were in fact patients of hyperparathyroidism. So, and the NICE guideline says that do calcium for everybody, for all the patients, because apparently from what I have searched across the platforms, the calcium levels, correct me if I'm wrong, it just only costs around 2 to 3 pounds per person. So it's relatively very cheap, but for example, even in my case, if you pick out 4.4% of the patients with hyperthyroid, like hyperparathyroidism, and you treat them, and they don't form stones later on, it's a win-win situation. It would increase the the efficiency of us, and it would decrease the cost burden of the NHS as well. Yes, so you know, lithotripsy machines, even if you have lithotripsy machines with stone formers, we can, like stentings and everything, an operation or any intervention is expensive. And it takes up a lot of NHS, money-wise, it drains NHS. So relatively cheaper alternatives just to deal with this is, I think, is a better option.
All right, Aram, we got a few questions from the panel from here.
Yes, please.
I'll ask Professor Saab to ask.
Thank you very much. I think this is a really important audit, and it's a very good example of a stage 1 and a stage 2 follow-up and showing improvement in results following actions taken. My question is about, in audits, it's really important to have lessons learned and how we can apply those lessons on a wider scale. Mm-hmm. So my question to you is, how do you intend to ensure that these findings are publicized elsewhere? Because I'm sure your lithotripsy department isn't the only place in the country which has got this problem. Yeah. So I think you've got a onus to ensure that this lesson is widespread. Yeah. So I didn't get a sense of what the literature says in terms of compliance and if you're going to disseminate findings.
So sorry. So what was your last?
So my question was really how you're going to ensure that the findings are disseminated, and what does your did you do a literature search to see how many other departments are following this kind of practice?
So we didn't do a literature search to be a proper one, but we had this discussion with our consultants as well, and from consultants coming from different backgrounds as well, and they all agreed that this is a common problem facing across the NHS, and yes, I agree that we should increase this to other trusts as well, and my consultant, Ms. Sarah Howells, she's quite keen on doing that. But as we have done recently, the loop just closed on 4th of October, we are still in that phasing process of how to get it on a broader scale spectrum.
So I understand that. So you haven't had the opportunity to do it yet, but how will you do it? So what are your plans? I suppose that's what I'm trying to understand.
We haven't made any plans at the moment.
Okay.
We are still in discussion with the team and everyone, so we haven't made that exact plans.
Fine.
I'm afraid my colleague here has just stolen my thunder. I was going to say, I thought your presentation was very good, and it's a very commonsensical thing, and I'm surprised nobody else has done it before, and I'm even more surprised that you haven't actually searched the literature, because the paper is fantastic, but for your benefit, even you can modify this one, you must have references, because otherwise, you know, people will simply think that you haven't done the work, and I'm sure you have.
Yeah.
Okay, just really a pointer for you, but excellent presentation. Thank you.
And thank you so much. Yeah.
So, I mean, I think, I know you haven't had a chance to think of it, but you should think about publishing it. You should think about presenting it at conferences like this. You should try to think about influencing the Royal College guidelines, all those kind of things. There's a number of ways you can disseminate research and audit findings. And I suppose my point was that it's really important to do that. And as my colleague said, literature search would be a good place to start.
Yeah, no, I agree. Yeah. Sure.
Thank you so much, Aram.
Thank
One
you.
of my question as well. You can't, yeah.
Sorry?
Yeah, please.
No. So sorry, I couldn't. So the NICE guidelines recommends that you do calcium levels for every stone patient, but the team at Oxford, the SHOs or the doctors, they are not like particularly following that to 100% compliance, that they are not getting the prescribing, like ordering calcium levels for the patients. That is what I meant. So, sorry, I couldn't. Yeah. 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 Oh. Yeah. 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 No, I understand that, and
Yeah. You're absolutely right, Mr.
I understand
Mr.
that,
Rashid.
and
My supplementary question was exactly the same. So,
but yeah.
Excuse me,
Yeah.
can we not make any negative comments, please? It's very important.
No.
This is for learning, it's not for berating.
No, I understand, and sorry, yeah. No, I totally agree with this. And we had this conversation in detail. This is exactly what I wanted personally, that we make it mandatory by the staff. But the problem with that was, there were a couple of problems. First problem was that with the EPR system, we cannot make a pinpoint mandatory calcium level testing to be done. It's an open text, anyone can fill, any referring person can fill it, and they can omit that exact wordings and still being able to refer the patient to the calcium department, to the lithotripsy department. The second problem that we faced was the staffing. There is a lithotripsy coordinator, but the nurses, they only have, at Churchill Hospital, they have only 2 nurses at Churchill Hospital dealing with all lithotripsy referrals. And they made it quite clear to us that it's going to be impossible for only them to triage, and plus they cannot prescribe. So, or order more calcium levels. So they said that it's going to, like, we had this detailed series of conversations with the IT guys and everybody, but that unfortunately we couldn't achieve. That is why you might have guessed, like, my first cycle was in March and the second was in October, because for the last 3-4 months in between, we tried really hard to make these changes, but this is the best possible overall outcome we could achieve in Oxford University hospitals, unfortunately. Otherwise, yeah.
Thank you so much. Thanks, Aram. Thank you. Let's proceed to the next one.
I'm just going to request everyone, please, and it's the responsibility of the panelists that the session should not go above the 8 minutes, including the presentation and question answer. What we're going to do, we're going to invite at the end all the presenter at the stage, and you guys can ask as many questions. But this session is only 5-minute presentation and 2 to 3 question and answer for the marking system and award distribution after that. But you guys have all the chances and everything at the end to ask as many questions as you can ask from the presenter. But please stick with the time because we have a schedule running for the day rest.
Thank you so much, Aram. Moving on to our next presentation, I would like to invite Usman Hanif.
Assalamu alaikum and good afternoon. So my poster is about a quality improvement project that we did, and I will just take you about this. So I will explain you about why we did this project, and I will take you the details, the pro forma we filled in, and what actions we did and the results. So while working on different wards, especially medicine, geriatrics wards, so I noted that there was quite non-compliance to prescribing of warfarin. So normally in my hospital, the warfarin is prescribed on paper charts, and there was quite non-compliance. And the idea to do and think about the audit was to improve the warfarin prescription and patient safety and avoid discharge delays. So we made a pro forma. You can see just an image glimpse of that contains about 11 to 12 questions. And we took about 102 patients on warfarin in medical wards across Leicester Royal Infirmary. And we reviewed the warfarin charts and filled in this pro forma between 5 to 6 p.m. over a month. The time was because warfarin is normally prescribed at 6 p.m. every day. I will not going to go in all of the question details, but you can see. So there was one question that we said, is the latest warfarin chart has with the usual dose been completed? So the compliant was just 16%. Similarly, that if it's properly signed by the doctor or a proper chart has been filled, the compliance was just 36%. Mainly, while on weekends, the patients, they miss the doses, saturation day, because, and the jobs goes to the on-call doctors, and that was just like, the compliance was very low. So we educated the junior doctors via teaching the importance of timely warfarin prescriptions. Major role was to be liaised with the IT services of the hospital, and we successfully managed to transfer the paper chart to the electronic EPR system. And then we created that warfarin has to be on electronic system, and there has to be an alert over there. So we just got an alert system on the EPR. So in the ward round, when the doctors go through all the medications, they can see that the warfarin is there, and it has to be prescribed because it has to be dosed every day according to the INR. So that was a good increase the compliance. And apart from that, we created awareness among the junior doctors to prescribe it on time, prescribe it for over the weekend, and via putting posters and emailing them. The next image just shares about the summary sheet. You can compare the first audit, and the compliance was 16%, but later on it went to 100% because we switched it to electronic prescription. But in some areas, we were still lacking with the compliant. But rest of the points, we got 100% achievement. So apart from these, we noticed that 65% of the patients were dosed properly, but although it can be dosed more. And average every day, there are about 50 to 60 patients on warfarin in the hospital. And 3 to 4 warfarin dose jobs were there created for the on-call team. When it was on the paper chart, so the junior doctor has to travel to the ward to find out the paper chart, to log into the computer, to get the INR and go back and dose it. So the average it takes 15 to 20 minutes just for this job. And by getting it onto the electronic system, we can just prescribe it remotely even it's missed. So that's the way we improved. So we improved patient safety. The doctors time was saved, and the trust got in cost benefit as well financially. It would less cost about this. Thank you very much.
Thank you so much, Usman. Yes. So any question from the audience? Okay. Right, so I've got to ask a question. What measures have you taken to educate the nurses? Because most of the wards, they have got nursing who does the drug rounds and stuff. That's the other thing to see if they can highlight problems. Because what we could see, there was slight improvement after, even in the second cycle.
Sorry, I didn't get you properly. Can you speak in the mic, please, a little bit?
What I'm asking is, what measures have you taken to educate the nurses, particularly nurses who does the drug rounds?
Yes, so we put on the board ward, there is a patient's board on the ward. So the patients who are on warfarin, we put a magnet over there, so they should be aware about that. And we requested the nursing team as well to request the junior doctors before they finish the shift to make sure that the warfarin has been dosed. Otherwise, it's like a main job of the doctors to prescribe warfarin. So the junior doctors were educated more.
Sorry, can you hear me?
Yes.
My question was about your patient sample and how representative is your patient sample of patients on warfarin in the hospital?
So as I mentioned, average 50 patients were there every day. And we filled 100 performers in the first cycle for over 30 days. And in the second cycle, we did again. So after 2-3 months of trying to educate the junior doctors, we did the same cycle again. So we did 100 performers, filled 100 performers. So we went, we collected the data about the 100 patients, and we checked the compliance. So 100 patients, so 100 different patients. It's not like the same patient every day or something. So the 100 patients, I would say. So if, for example, we did an audit today, so we might have filled 6 patients or performers today. Tomorrow, maybe 10 performers filled in. So when we got 100 performers filled, 100 patients data, we got it. So then we made the data.
Thank you so much, Usman. Thank you.
Thank you.
Thank you, Usman. Now we have a next poster presenter, is Sadia Ranja.
Hi, good afternoon, everyone. Can you hear me all right? So I've just put a brief algorithm together on malaria chemoprophylaxis today, so it's not a sort of in-depth or anything like really comprehensive, but just a quick overview of what we would do. So I'm also a medical student, but I'm a pharmacist. So during my time working as a pharmacist, I identified like the sort of need like we had with patients and the travellers that were kind of going off to malaria endemic regions. And quite a lot of people had like a really like lack of knowledge and education around malaria and the risks that are associated with like traveling to these areas. And you know, it was just phenomenal the amount of like lack of education that they had. So I identified need and put in place like a travel clinic within the pharmacy that I was working in. So I put together an algorithm and I focused on malaria because travel medicine's huge. So malaria remains as like one of the most commonest imported infections in the UK. Up to 2,000 cases are reported each year, and it's a portion of like 3/4 of people cases that are reported are of malaria falciparum, so which is like the most debilitating, like most life-threatening version of the Plasmodium species, as we recognise it. And so it's important to sort of tackle this and sort of be aware and do our best as we can, because it's like a public health initiative for that respect. So I thought I'd start off by talking a little bit about what the most commonest type of traveller that you sort of see in the farm, like not in just in pharmacy, but how you would see. So does anybody want to have a go at what is the most common type of, your average type of traveller that you would see? Does anybody have any ideas about that? Any guesses? Yeah, absolutely. That's one of the, so basically 3/4 of people is associated in West Africa in particular, but also the VFRs, we call them, visiting friends and family, remain like the highest proportion of the average type of travellers that kind of bring back the malaria to the UK. So these are friends and families that are travelling to sort of rural, remote areas, and they have like very little awareness, and they feel like, oh, just because they are born from Africa that they will be immune to malaria. But typically when you leave the country over a year, then you are at the same risk as anybody else of like contracting malaria again. So that remains one of the biggest kind of misconceptions around that. So that's what the average traveller is, and I've mentioned a little bit about vulnerable travellers there and some information in regards to that and itineraries, and it's important for me as a pharmacist to sort of look at a comprehensive travel risk assessment, which I kind of organise into sort of itineraries and where they're off to and making sure that they've got the correct chemoprophylaxis. But also I thought I'd touch a little bit about pathophysiology, because we all, like medics, we like to talk about pathophys. And so the bite of an infected Anopheles mosquito that travels as the sporocytes, as they say, are injected, carried through the bloodstream towards the liver, which then we develop like multinuclei schizonts, which then a couple of weeks after, during the blood stages of the malaria parasite, would then rupture into merozoites. And then it's these merozoites that are then feed off the hemoglobin within the erythrocytes, which is then that's the way it repeats itself, the cycle. But some of these merozoites can also, the trophozoites can then form into gametocytes, into the sex, male and female sex cells. So then in that way, we wait for another Anopheles mosquito to bite and then start again. So that's a little bit of pathophys. And then I thought I'd end with the sort of treatment of chemoprophylaxis, as they call it. So talking about the malaria endemic regions like West Africa and Southeast Asia typically are the key hotspots. We would use first line, according to NICE, the atorvaquone proguanil, which is kind of, they call it Malarone. When you have contraindications, for example, if people cannot tolerate that, you would have something called doxycycline. You also got mefloquine as well, malarium as they call it, but you would avoid in people with psychiatric conditions and things. So in this way, I was able to sort of risk categorize people coming into the pharmacy and just a basic algorithm for somebody else to use, like an easy tool of what exactly to do. So I guess if there's any questions around that, I've put some references on specialist referral as well. If where something is outside my limits of competence, I have a reference point to go to. Being a prescriber as well, I can sort of recognise signs and then refer them people for treatment if need be as well. So thank you for your time. Any questions?
Thank you very much. Do we have any questions from the hall?
I mean, that's an interesting question. It's something that I've always asked my consultants in infectious diseases as well. I feel like when you live there and you've developed and contracted it, I do feel like you are immune to a certain stage because you're, like you say, it's continuously within. But I think leaving the area for years and years, and then you do become, which I don't think there's any evidence behind the pathophys of how that happens, but I do believe that they then become non-immune, which has then been reported, and there's evidence of cases as well.
Thank you. Any other questions from the hall? Thank you. Okay. So, yeah. So I'm just going to ask you a brief question. You've given us quite a comprehensive sort of one-page document on the prophylaxis and treatment, etc. You haven't mentioned the actual malaria vaccine that's currently being discussed at the moment. Do you know how long it's going to take for that to be in place? Because that would then replace all these different prophylaxis regimes, wouldn't it?
I think it's still being sat in the decision of the panels of the joint vaccine committees and NICE, and I think it's about approval and evidence and testing it in enough patients for it then to become established. It's like the COVID, it was sat in the Joint Vaccine Committee for a long, long time, but obviously with the urgency that was needed, I think they have tested it. It's working quite successfully in that cohort in West Africa, but for it to be more established worldwide, it's going to need more time, because there's a range of like vulnerable patients, there's pregnant patients, there's child patients, and for it to be tested across the range of people, it's going to take more time. But I know there's talks about it. I haven't kind of mentioned it on here because it's not like an established chemoprophylaxis, as I say, on NICE.
It is actually cutting-edge technology that's been publicised just in the past month. Thank you very much.
Okay, no problem. Any other questions?
No, that's it.
Okay, thank you very much.
Thank you, Sadia, for an excellent presentation. Now we have a next presenter is Lauren Molany.
Hello everyone, my name's Lauren. I'm a Foundation Year 2 doctor at Manchester Royal, and today I'm going to present the results of the first cycle of my audit. And this audit was based on NG tube placement and documentation in the patient notes after the patients have chest x-rays to confirm the positioning. So the rationale behind this project is based on a national patient safety alert, which was first issued back in 2005. And as I'm sure most of you are aware, the misuse of a misplaced nasogastric tube is a never event. However, despite this, since 2005, there's still been 95 incidents of this, and unfortunately, 32 of these patients sadly passed away. So my audit was based on whether we're documenting correctly in the patient notes. So there was a number of reasons identified for these incidents where the patients had misplaced nasogastric tubes. So firstly, the reasons they identified was the misinterpretation of the chest x-rays. Secondly, it was nursing staff and problems with the pH testing. Thirdly, it was unapproved methods being used to check the NG tubes. And finally, it was communication failures. So in my hospital, which is different to, I think, other hospitals, radiologists interpret all of the NG tube chest x-rays, and then it's a job for us as junior doctors to document the radiologist reports within the notes. So what I was looking at is whether us as junior doctors are documenting the reports correctly in the notes so that the nursing staff can see this and safely use the NG tube. So the aim of my project was to measure the compliance against the National Patient Safety Alert, which was issued in 2011. And the standard was that 100% of these chest x-rays performed should be documented fully in the patient notes. So what's required for full documentation? So the grade of the interpreter should be documented, the confirmation that was the most recent chest x-ray, and then there should be clear instructions for action, so whether it's safe to feed the patient afterwards. So my sample was taken from Manchester Royal Infirmary and 46 patients were used, and it was a retrospective data collection. And at my hospital, we use a completely online system called EPPNE, which I think is used at some other hospitals as well. So I was looking specifically at the notes section of EPPNE, which is what's replaced the paper patient notes at my hospital. So as you can see on the screen, these are the findings. So although we are documenting quite well in the patient notes, only 63% of these patients who had had these x-rays had some documentation in the notes section. And in 24 of them, the grade of the interpreter had been documented. In 17%, there was confirmation it was the most recent x-ray, and in 54%, there was clear instructions. So only in 9% were all of these requirements met. So what we can see from this is that there is reduced compliance against the National Patient Safety Alert because we aren't fully documenting this in the notes section. And this is a possible area for miscommunication. So just to be clear, the radiologist reports are correctly documenting it, but then as junior doctors, we aren't correctly transferring this information so the nursing staff can see. So I'm planning to re-audit this and do a second cycle. But before I do this, I'm going to create some changes and recommendations. So firstly, I plan to spread awareness to the junior doctors of the requirements that they need to put in the full documentation, because this isn't something that I think everyone's aware of. So I'm going to create posters and present at my hospital to make everyone aware of this. And secondly, I'm generating a pre-formatted table which can be easily accessed on the online system. So we have something called smart phrases. So you just put like a full stop. So you could type full stop NG tube, and then the pre-formatted table which I've created would appear in the patient notes so that the junior doctors can document fully. And then thirdly, I plan to work with the software team at the hospital to see if we can pull through the radiologist reports into the notes section so that they're easily accessible for the nursing staff to see. Yeah, thank you.
Thank you. We're just going to ask a question from the panelists now.
Thank you. So being a radiologist, that's a very, very important topic and close to my heart. So can a couple of questions in the interest of time? Obviously, we can be here for a very long time if we start discussing this rather critical topic. But with regards to the interpreter grade, do you have a specific instructions for only consultant radiologists to authorize these reports in your hospital? So that was the first question.
So in our hospital, it's any radiologist, any reporting specialist trained reporting radiographers that can interpret these chest x-rays. And then if it's out of hours, it's people who are registrars, like medical registrars that have completed extra training, they're allowed to interpret the x-rays. But other than that, no one else is allowed to interpret.
So any authorized report on the system, but not necessarily consultant report?
Yeah.
Okay. So the second thing which I wanted to ask was the time frame during which these reports are actioned. Is it only a particular period of the day time, or is it 24 hours when these reports? Because some of the hospitals which we have worked with on this topic have limited action times between 9 to 9 or 8 to 10, and not because of the simple fact that ideally we should not be using the NG-tube for the first time during the night. So is that something which is also practiced in your institution, or is this something different?
So at our hospital, I believe that the reports are interpreted between 8 a.m. in the morning and 6 p.m. in the evening by the radiology department. And then when it's out of hours, as I said before, if it's urgent, then a medical registrar with the appropriate training is allowed to interpret them. But that's, I think, to prevent starting NG feeds overnight and the risks associated with that.
Lovely. Thank you very much.
Thank you.
Thank you very much.
Thank you.
Thank you so much, Lauren. So our next presenter is Shayan Sumro.
Well, unfortunately, the data's been clouded a little bit, so I'll just talk through it. My name's Shayan Sumro. I'm one of the Foundation Year 2 doctors at Sandwell and West Birmingham hospitals. So I did a 2-round closed-loop audit on annual follow-up blood tests for post-bariatric surgery, and this basically analysed 3 Norfolk GP practices. So I decided to do this because obesity is becoming a more common problem, especially in the UK and the Western world. There's rising rates, and associated with it are severe comorbidities, such as ischemic heart disease, for example. The different types of bariatric surgery that you can get are gastric banding, sleeve gastrectomies, and also gastric bypass as well. And usually it's done sort of for BMIs that are over 40, or BMIs that are over 35 with severe comorbidities as well. Several studies have also shown that associated with bariatric surgery, you can get severe nutritional deficiencies, especially because surgery is a state of inflammation. It can cause absorption problems. And studies have also found that there's common problems with vitamin D, iron levels, mean corpuscular volume of hemoglobin, etc. So other studies have also shown that after these kinds of surgeries, a lot of patients do require supplementation, especially with things like calcium and vitamin D. In terms of other audits that have assessed follow-up post-bariatric surgery, we did a literature search, and we found that generally compliance is actually pretty poor amongst GPs, and we found that only 62% of patients actually get followed up within the first year of their bariatric surgery. So essentially, my audit aims to assess how many patients underwent bariatric surgery, how many were followed up within a year, which bloods they received during the follow-up, and whether they met the guidance. The guidance is essentially set out by the British Obesity and Metabolic Surgery Society guidelines, and this includes doing blood tests for full blood count, urea and electrolytes, liver function tests, bone profile, fat-soluble vitamins, copper, zinc, and selenium. Our criteria and standards were to achieve 100% follow-up of patients within the first year of their bariatric surgery, and with 100% of those receiving a complete set of blood results. In terms of the methods that I used, I looked at the GP practices System 1, and from the 3 practices, we identified 24 patients, of which only 22 were analysed because the key terms that we used included laparoscopic surgery, but not specifically gastric banding. The notes were then searched to check follow-up in the year following their bariatric surgery, and blood results were also analysed to see which were done and which were missed. Those that were missed, letters were then sent to those patients, inviting them for a re-follow-up and to then have those tests done. We used descriptive statistics to assess the compliance to the British Obesity and Metabolic Surgery guidance. In terms of our results, so in round one, we found that 68.2% of patients that had bariatric surgery were followed up within the first year of their surgery, and 0% of those had a complete set of blood results. Out of those that did have blood results, liver function tests, urea electrolytes, and full blood counts were the commonest to be tested. Parathyroid hormone, vitamin D, copper, zinc, and selenium were the lowest. This did increase substantially in round two. So 91% follow-up was achieved in round two, and with those that were followed up, 100% of those received a complete set of blood results. Those patients that didn't turn up to follow-up did not attend their appointments for various reasons. So, in terms of recommendations, it's important to follow up bariatric surgery patients within the first year of their surgery, A, to assess nutritional status, and also to identify nutritional deficiencies so they can be adequately supplemented. This hopes to reduce severe adverse effects that can have long-term effects on patients' quality of life, including anemia, osteoporosis, and other serious conditions, including acute kidney injury and acute liver failure as well. Thank you very much.
Thank you. All right, Sean, thank you so much. Nice presentation. Question from my side is, I want to know, you have got only, I believe, 22 patients in 1 year, and it's only sleeve gastrectomy. You didn't have any bypasses patient.
So we had a variety of the different patients. There was a sort of equal split amongst the three practices. So I think it was 7, 7, and it was like 8, 7, and 7 across the three practices for the three surgeries.
Do you think is there any difference in blood tests between two cohorts, bypasses or sleeve gastrectomies, because both are different kind of operations?
I think there will be some sort of intersurgery variabilities between the three. During my literature search, I didn't specifically encounter any differences between those three in terms of what the complications are, but I can imagine there probably would be.
No, the sleeve gastrectomy, I think you mentioned, is mostly sleeve gastrectomy. That's a restrictive operation, and the bypass is malabsorption. So the bypass is the one which possibly need more extensive blood tests. So I wanted to know how many bypasses were there, or is there any difference in blood tests for both cohorts?
So according to the guidance, there isn't actually any specific differences in which blood tests should be performed. That's not what the guidance specifically says. I think it says it generally for all for all banding patients, essentially.
Thank you.
Again, thank you very much for it's good to see the second round of the audit here as well. My question was, how do you thought about how do we automate this and to make sure that it takes it out of someone's, sort of thinking about it and make it, so how do we do that?
So I think with this, it was good to audit because obviously we could then find whether there was actually a limitation in who had received appropriate follow-up blood tests. So I think instead of then having to manually send letters, I think patients that do tend to have, or that do have bariatric surgery, in their notes there should be sort of an automated update that quite a lot of electronic systems do now have, where a pop-up will appear anytime you enter their notes to alert healthcare practitioners to then have some sort of idea as to when their next follow-up appointment should be. And this should also not include just doctors, but also specialist nurses that will be attending and doing these clinics, who will then be aware that a patient might need follow-up in the next sort of couple of months. And that way, they'll have plenty of time to then send letters to those patients, inviting them for a follow-up.
Thank you.
Thank you.
Thank you, Sean. Thank you, Sean. Now our next presenter is Dr. Anis Selva.
Good afternoon, everyone. My name is Salwa Anis. I'm one of the SHOs working in...
Just use this mic.
Yeah.
Try again.
Hello? Yeah. Hi, everyone. My name is Salwa Anis. I'm one of the SHOs working in University Hospitals of Leicester. Today, the topic of my presentation is importance of bedside echocardiography in aiding the diagnosis and management of pulmonary embolism. Just to give you a bit of a background, pulmonary embolism is the third most leading cause of cardiovascular death worldwide. European Society of Cardiology has published guidelines which state that bedside echocardiography is important in risk stratification of patients who present with acute symptoms. It can be vital and it can help us to aid the diagnosis and thus prompt early intervention. Here we present a lady, a 72-year-old female who presented with collapse, shortness of breath, and abdominal tenderness. Her blood pressure at presentation was stable. It was 140/90. I'm sorry, it's missed there in the slide right here. Her heart rate was 150. Initial blood tests, all were normal, including the chest X-ray inflammatory markers. An ECG was showing no features of pulmonary embolisms, which are the typical features of pulmonary embolism. Rather, it was showing an atrial flutter. A bedside echocardiography was done initially because, as the patient presented with syncope, to just rule out any valvular pathologies or outflow tract obstruction. And the bedside echocardiography showed us that the right ventricle is dilated and there was akinesia of the right ventricle. Furthermore, it also showed a thrombus which was pending into the right atrium and the right ventricle, not shown in the image right here, because this was done on a handheld bedside echo device. This raised a strong suspicion of pulmonary embolism. Please do bear in mind that the patient was hemodynamically stable. A CTPA was done, which further confirmed the presence of a saddle PE and right heart strain as evident by the enlarged right ventricle and straightening of the interventricular septum. This was discussed with the patient, and based on the presence of right ventricle dysfunction, a new thrombus which had potential risk of being extending or the volume being expanded, she was thrombolized with altiplase 10 mg as stat followed by 90 mg as a slow infusion. In summary, the conclusion of this is that bedside echocardiography is important because it helps us to risk stratify pulmonary embolism, and then the risk stratification of pulmonary embolism is important because it guides us regarding the mortality. It is easily accessible and it is a non-invasive method. Therefore, it can help us and prompt early intervention. Thank you very much.
Thank you so much. We have a couple of questions here.
Thank you. I mean, it's a very interesting presentation, and I think a couple of things. Point-of-care ultrasound is becoming quite common, including, of course, echocardiogram. Given that at the moment, the CTPA pickup is around 30% for pulmonary embolism, do you think there is a role of doing a bedside echocardiogram to better risk stratify patients before going down the route of CTPA for everybody who is sort of in a 50-yard diameter of A&E?
Yeah. So I completely agree with you because CTPA has become quite common. But as I said, bedside echocardiography is not easily accessible, first of all. The second thing is by the time we request a CTPA, we call the radiologist to vet it, then there is a waiting list on the CT scanner for the patient to come in. Sometimes urgent scans do happen, but initially it can guide us and then prompt early intervention. CTPA might be done in a couple of hours, but I believe if a physician is present, bedside echo can be done in the first 10-15 minutes of presentation.
So, that's separate. What I was trying to say was that perhaps instead of getting a CTPA in rather unwell patients where because of tachypnea we end up with a non-diagnostic study, perhaps it may be useful if you explore whether you can deploy this more commonly as a technique to better stratify those patients who really need a CTPA rather than everybody who has got shortness of breath, because unfortunately, because of the fact that we are doing it in so many patients, the pickup rate for PE on CTPA is 30%, which is not really good. So yeah, thank you.
Question from my side is, echocardiogram does need expertise to do it on bedside. What is the, facilities available, or you think would the NHS need in this regard for acute patients?
I believe it's coming from my side because I work in a department where a lot of people are trained in echocardiograph, and this is something which I've seen very commonly. As I think what most of the physicians are being trained in echocardiography, even if they are not cardiologists, especially with the famous course and the POCUS courses going around.
Thank you so much. Dr. Haider? Go next one. Thank you.
Thank you so much. Thank you so much, Selva. Moving on to our next presenter, I would like to invite Lisa Heather.
Good afternoon, everyone. I'm Lisa, currently a third-year medical student at the University of Liverpool. To begin my presentation, I would like to share with you that in 2022, the World Health Organization shared a concerning statistic that 1 in 4 people will experience a stroke in their lifetime. This is a startling reality, and one of the factors linked to strokes is patent foramen veil, or PFO, which is present in 20 to 30% of the general population. In cases of cryptogenic stroke, the prevalence of PFO rises to 66%, suggesting a connection. Today, I want to present a study published in 2018 that aimed to shed light on the treatment options for cryptogenic stroke in patients by analysing the outcomes of 5 randomised control trials, focusing on the reoccurrence of stroke. The meta-analysis methodology pulls results from independent studies to provide a comprehensive view of the effectiveness of transcatheter PFO closure compared to medical therapy alone, the medical therapy being antiplatelets and anticoagulation combination therapy. The research involved an extensive search across 4 reliable databases, applying strict inclusion criteria. The selected RCTs included a substantial sample size of 3,440 patients, with the primary outcome being recurrence of stroke. Secondary outcomes included transient ischemic attacks, atrial fibrillation and flutter, adverse events and device-related complications, and all-cause mortality. The primary method of each RCT was consistent. Patients were divided into 2 arms, one receiving PFO closure and the other receiving medical therapy alone. However, subgroup analyses revealed variations in types of closure devices. So one of the discrepancies was only 2 trials used a single model of closure device, and among the remaining trials, a minimum of 7 different devices were used. Another discrepancy was the grade of interatrial shunt in the study population was not declared, which could directly impact device-related complications and the primary outcome of reoccurrence of stroke. These differences among the trials raised questions about the reliability of the analysis. Moving on to results, the study found that PFO closure reduced the reoccurrence of stroke overall, with 1.9% of patients in the PFO closure group having a reoccurrence and 4.24% in the medical therapy group having a reoccurrence. Most secondary outcomes showed no significant differences between the 2 groups, but still there was an association between PFO closure and an increased risk of new onset atrial fibrillation or flutter and pulmonary embolism. Considering that stroke has multiple causes, comorbidities of the study population play a crucial role in drawing accurate conclusions. The study failed to account for factors like age, gender, diabetes, and other health conditions that can influence the stroke risk. In conclusion, this comprehensive study recommends changes in the treatment of PFO following cryptogenic stroke, highlighting the advantages of PFO closure. However, the potential risk of new onset AF or flutter as a result of device implantation calls for further research, especially considering factors like grade of shunting and device specificity. The study underlines the importance of continually exploring the best approaches to treat and prevent strokes. Thank you for your attention.
Thank you, Aliza.
Aliza, thank you very much. That's a wonderful presentation. I must congratulate you on your background, which is particularly engaging. Perhaps because of the interest of not making the slides particularly busy, you haven't touched on how did you actually image these patients to confirm a patent foramen ovale, and did you do bubble echo or did you use some other technique?
Sorry, what was the last sentence that you just said?
The imaging modality, did you actually use imaging modality to confirm that they have a patent foramen ovale?
So the trial that I'm talking about, the patients had already had cryptogenic stroke, all of them, the entire study population, so 3,440 of the patients. They then checked which ones had PFOs and then either treated it with, so after the stroke reoccurrence, treated them either with a surgical closure, so a transcatheter closure, or medical therapy alone, which was antiplatelets and anticoagulation, and then monitored them for 4 years was the average follow-up.
But during this trial, they were not imaged to confirm whether there was actually a patent foramen ovale at the time when they had a stroke. So there was no imaging done to confirm that.
Well, to be able to surgically close a PFO, they would have had to image to see if there was one there. That's my logic behind it. So I think they did do imaging.
Because my follow-on question was, if there was any imaging done at the time of confirmation of a PFO, did you actually deploy the same modality to follow up? But I think that particular component of the trial is not particularly forthcoming. So I probably would, because, yes, it is most likely that there is a PFO if you've got cryptogenic stroke, but it is useful to actually have confirmation. And the most common modality, the most cost-effective modality is bubble echo. So out of interest, I just wanted to find out whether there was any imaging modality deployed. Thank you.
Thank you.
Thanks, Lisa. My only question is, this is a meta-analysis.
Mm-hmm.
How many RCTs were included?
5.
5. And how many patients were in each arms at the time when the meta-analysis was done?
Oh, you're asking exact numbers there. I know the patient population size over all 5 RCTs was around 3,440. Some RCTs were bigger than others. This trial, all 5 were done in America. But I would have to look at the exact numbers of each RCT to give you.
All right, thank you so much. Thanks, everyone.
Thank you.
Thank you, Lisa. Our next presenter is Zara Iftikhar.
Hello guys, sorry actually this is not my poster, so they are just going to change it. No? Yeah, that's fine. Yeah. Hi, my name is Zara Iftikhar and I'm working as a registrar in Queen's Medical Center, Nottingham. Sorry, actually I'm having some sore throat, so I wouldn't have a good voice today. So I'm going to present my audit on the collection of cord blood gases after instrumental vaginal deliveries It would be more interesting for the obstetricians, basically, because it's taken from the maternity. I did this audit in my previous trust in Basingstoke, North Hampshire Hospital, and I did it at the very end when I left the trust, unfortunately, and I couldn't complete the loop. But this is the first audit I have done. So the objective of this audit was that I wanted to determine that whether my department was following and meeting the RCOG guidelines on collection of cord blood gases after instrumental deliveries, because it's very important topic for the obstetricians. Basically, it's very important medico-legally that the cord blood gases should be documented properly, and it's mentioned, the reference is taken from the RCOG Green Top Guideline Governance Issue section. They have said that 100% of the cord blood gases should be taken after all inoperative vaginal deliveries. So my trust was using the system we called BadgerNet for the documentation. So we did a retrospective analysis, which was done over 6 months period from May 2021 to October 2021, and we collected the data from BadgerNet, and so total, there were 1,350 deliveries, normal deliveries in the 6 months period, and only there was 144 patients were on the BadgerNet, whose cord blood gases were documented on BadgerNet. And if I just cut short, if we look at the data analysis, so in total, out of 144 patients who had operative vaginal deliveries, only 126, which makes 88%, had cord blood gases taken, and 12% had missing data, and only out of that 88%, 62% patients for cord blood gases were documented on the BadgerNet. And the people whose blood gases we couldn't find on the BadgerNet, we tried to explore paper notes, and then the ones whose cord blood gases were not documented in the paper notes, we tried to explore the blood gas machine. And I wanted to do it as a quality improvement project. I presented this audit in my local audit meeting, and they were very happy. They said that it should be done again in 3 months' time and close the loop, but unfortunately left the trust and couldn't do it, and I'm trying to do it in my new trust now. So if you have any questions for me, you can ask.
Thank you very much, Zara. I've not seen a study like this before, and I think it's very interesting and very pertinent. The data was collected retrospectively between May 21 and October 21. Was there a particular reason that this was done as far as the newborn was concerned?
Actually, the BadgerNet was introduced, it wasn't introduced very long ago in that trust. So they were working on BadgerNet to learn it. So that's why we did this audit to make sure that are we doing it at the right place, are we learning BadgerNet how to use the BadgerNet. So basically we were checking the compliance of the midwives, that how they are using this system, and that's why we choose this one.
I was just thinking about the outcome, the reason for doing it. Was it because of any kind of neurological deficit in the newborn, the children?
Sorry, can you repeat the question? Sorry, I couldn't hear.
For every audit that's done, and for the reason for any audit, there's usually a reason behind it, something that triggers and stimulates a person to actually do a study like this. Did you consider the effect of the newborn baby? Did they show any signs of any kind of neurological deficit, like developmental delays or learning disabilities or anything? Did you look at that at all?
Actually, we didn't look at that particular thing, which children did have neurological deficit or not. No, that wasn't included in our audit. We just looked at the compliance of how to improve the quality of using the BadgerNet. We didn't look at the outcome of the children whose cord blood gases was really odd, like they were just really off. So we didn't look at that, no.
Thank you.
Thank you.
Thank you. It seems like a retrospective audit. My question is, you got 88% captured, 62% from your BadgerNet. How did you manage to capture the rest of it?
How did I manage to capture them from BadgerNet?
No. You got 62% from BadgerNet. In
Yeah.
total, you had 88%.
Yes.
So how did you manage the rest of it?
Rest of them?
Yeah, did you have to go through the notes?
Exactly. We went to the paper notes, we explored the paper notes, and then even in cord blood gases from, I think I've mentioned here that we could find only for 55 patients, which was around 31% we could find in the paper notes. But then the patients who we couldn't find, then we went to the blood gas machine, because midwives sometimes, it's all stored in the blood gas machine. Then we checked the blood gas machine, and there were around 53% were documented in there, but still we couldn't find data from anywhere for at least 12% of the patients. So I don't know what happened, were they not really done, or if they were done, they were missing. So we never knew that what happened for 12%.
You presented almost a 2-year-old data here. You said BadgerNet was there, has not been re-audited since then.
No, actually, there were no previous audits on this topic, and this topic wasn't even mentioned in our trust guidelines. But in RCOG, it's mentioned in the RCOG guideline, but it's not. So it wasn't mentioned in our trust guideline even. So that's what we implemented these changes.
So if I added Dr. Shamim's question with my question, so why did he use 2021 data? And if that was the case, then BadgerNet has not been properly used since then.
Yeah, because I was working there last year, so we collected retrospectively over that 6 months. I don't know what was the particular reason why I chose over those 6 months, but yeah, we just wanted to, because I think that was started not very long ago. BadgerNet was there, so that's why I think we took that particular data. So they were working really well when I left the trust. They were really improving their work on the BadgerNet, so I hope so that.
So is somebody planning to close the loop?
Actually, I just lost the contact with the people from there, but it was definitely presented at the meeting. I presented it, and it was on the system. I informed my consultant, and they said that they will re-audit. Somebody else will re-audit it, but I don't know if somebody has did it now, because I don't know the people there have moved from very far now, so I don't know. But I'm trying to do it again in my trust, because this is same thing happening in here as well.
Thank you so much.
Thank you.
Thank you, Dr. Zara. Now our next presenter is Dr. Irfan Khan, and I must say he has been struggling to reach there, and I'm really glad that he managed to come at last. So thank you, Irfan, for coming, and the round of applause for you.
Thank you, everyone. Sorry, it seemed like a very busy poster because I couldn't get opportunity to skim through all the data. This is actually one of the case reports related to a very rare condition that we encountered in Heber Teaching Hospital, Peshawar, when I was doing my postgraduate training in medicine there. So I'm sorry for the poster. It's, again, not a very good poster because I had to make it in my way to here. Actually, this is about a 45-year-old lady who had a background diagnosis of neurofibromatosis type 1, who presented to us actually with a mass in left axilla. So she reported that she had been having this mass for 2 months, which was growing and was causing increasing discomfort. This is why she sought medical attention. Because in Pakistan, we usually don't have a very good medical record keeping. But after examining her and going through her notes, we found out that she has having a diagnosis of neurofibromatosis already. This prompted us to look for the differential of the mass because it was growing in size and was causing increasing discomfort. Therefore, we started with this simple blood labs investigation, which were essentially unremarkable. Later on, when an X-ray was done, it showed that she has definitely a soft tissue mass, which was now growing and infiltrating patient intercostal spaces, as well as also trying to indenting on the humerus as well. Therefore, we decided to go for MR of this MR scan, which showed, of course, a mass of 14.5 into 13.3 into 1.8, which was a heterogeneous large mixed signal intensity mass in the left axilla, which was infiltrating anterior intercostal space along with proximal humerus. This mass was growing alongside the brachiobrachialis muscle and also stretching outlying the pectoralis major as well as adjacent latissimus dorsi muscle. Therefore, we were going in line of now, of course, leiomyoma and leiomyosarcoma, which is commonly associated with this condition. Therefore, we decided to biopsy the lesion. We took a true-cut biopsy, which then showed multiple neoplastic lesion composed of pleomorphic round to elongated atypical cells with eosinophilic cytoplasm, along with atypical hyperchromic nuclei with inconspicuous nucleoli, which was consistent with the diagnosis of leiomyosarcoma. Therefore, she was then, of course, referred to, she was discussed different treatment options with her, one of which was the surgical excision. However, she decided not to go for surgery. Therefore, she was then referred to the neuro-oncology. And unfortunately, from there on, she lost the follow-up with the oncologist as well. So this was one of the very rare case presentation that we reported, which is published now in the Curious Journal of Medical Sciences. However, so of course, it will be difficult to read all because, again, unfortunately, I couldn't skim through all the information on 11th hour. But the take-home message was that usually patient with a condition like neurofibromatosis, which of course predisposed to other malignant condition, should have regular surveillance. This is in order to make a timely diagnosis of any such complication if develops, and so the timely management and better outcome. So this was one of the very rare case presentation. I don't know, nobody would be able to read through all the information, but.
Thank you very much. That was actually quite comprehensive, and as you're saying, an extremely rare presentation.
Yeah.
I don't actually have any questions. It's a very good presentation, though. Thank you.
Thank you.
Anybody else got any questions from the panel? Thank you.
Thank you.
While all the judges are marking your posters, I think we should applause for all of you for an excellent presentation and came all the way forward, and especially the medical students and the young doctors who are the future of APPNE. We are extremely grateful for you guys to come forward and present your posters. So what will happen now, we will present first, second, and third prizes in the presence of our President, Mr. Amir Khan. And after that, we will have a 5 or 10 minutes break. And then please be seated there because APPNE introducing now APPNE Youth Forum. And some of the children of APPNE members kindly volunteered themselves to come with the different ideas and take this APPNE forward. So thank you once again, guys. Thank you, everyone, for your patience. Sorry about that. I think it's quite tricky to mark because you guys did an excellent job, and marks are very close. So I'm going to invite our president, Mr. Amir Khan, to come and announce the prizes. Mr. Amir Khan, please.
Thank you very much, and it's great to find out that all the presentations of very high standard, and talking to the colleagues who marked it, it looks like it wasn't an easy decision. But first of all, congratulations to everyone who presented, because you're all winners, because coming and presenting is the most important part of the whole process itself. At the end of the day, unfoil system does demand that someone scores more than the others, but that does not matter. The ones who are not, who haven't won today doesn't mean their presentations wasn't of standard, but it's just the competition they were having. So thank you very much for all those who presented, and thank you for the organizers, and thank you very much for my colleagues who helped to mark these presentations. So first of all, I'd like to start from the bottom and then work upwards. It's interesting. On the third position, there are two with equal score, and they are Arham Kokar. Please come up to the stage, please. And Zana Sindhu. Please. Come on, please. Come, guys, well done.
Come on, why are you scared? Come on. Yeah, she's coming as well, but just...
Yeah, you can just go.
Thank you very much. You'll get your gift. It'll come to you.
Yeah. You can stand
stay
there.
there,
Stand there.
Yeah. Hello, Zaina. Thank you very much. Thanks for the presentation. Excellent work. Well done. Please come. Thanks. Right. Again, for second position, interestingly, there are again two people who've scored the same. So they are Lisa Heather.
Yeah, she's coming.
Oh, there she is.
Yeah.
I think this light isn't the best place for it. We'll have to change it.
Yeah.
And Cheyenne Sumro, please. Congratulations.
Thank you.
Congratulations. Please come over. Hello, Shahan. Congratulations. Well done. Please. Now comes the moment for who is the highest scorer. Lauren Maloney, please. I think in all these, the important part is the presentation, preparing it and presenting it. Don't worry about the scores because this is all purely theoretical. So the people who've done well, that's fantastic, excellent to them. Congratulations to all of them. Please come over.
Yeah.
Hi, well done. Congratulations. Please come over. There's a great team here, and I'm sure they're going to have several more occasions when they'll be doing the presentations. Keep this work up. Can I request the colleagues who marked it, please come over and stand with them so we can have a photograph together. Please, Habib and Samreen, those who organized it, please get there with them. Mar, chale. Please. Thank you very much.
We're going to invite all the people.
Yeah. Can we have all the presenters, please?
Please come over, guys. You've done a great job, to be honest with you.
Well done,
excellent. Well done.
Excellent.
Please come. Please. Hello, please. Come. Please.
Few people come to the center. Come on.
You can even.
Please.
Thank you very much.
Thank you so much.
Thanks, everyone. Give a big hand to everyone, please.
Thank you. Amit bhai, please get us it.
Certificates and all of that afterwards.
Yes, you guys going to receive an email for your certificate and prizes as well. Okay. Thank you. Just to let everybody know, the first prize is voucher, which is about £100. Second prize voucher is 75, and third prize voucher is about £50. We will going to email you and also send you your certificate as well. I would like us to guys to stay there, especially the part of the APPNE Youth Forum, the junior doctors who can also stay there as well if they would like to include their ideas and thoughts. We have few children who actually kindly volunteer, belong to APPNE family. I will invite first with Zaina Sindhu on the stage, please. Qasim Suhail. Ahmed Waraich. Shian Somro, Lisa Heather. This is your time, guys, to discuss your thought process and give us a way forward. And Mr. Amir Khan would like to also say a few words. I will just ask him to just say a few words about it.
Where is... Great. Thank you very much. I think this is a very important part of the whole function today, because I'm a firm believer that youth is the future, and you are the people who are going to run not just APPNE, but also NHS in this country. So it's important that we involve the youth at this stage. And I think what I want to do is that we don't want to influence how you plan it, how you want to run it. The purpose of this today's meeting is to sit you all together. We've got certain aspirations which we put on that, but this is not written in stone. You people can discuss them and decide how you want to take it forward. And what I'd like you people to do is go through all that, have discussion amongst yourselves, and provide us a working plan afterwards. Because what we want to do is, in future, we want to include you not just in this function, but in most of the activities which APPNE does. And I would very much like the youth to start their own activities and involve as many youngsters as possible. There are, I tell you, especially I'm in this area, I see Birmingham Medical School is full of our young students who come from Pakistan. Same as junior doctors. So this is the time for you to develop, discuss these, come up with a plan, and we'll work with you. Thank you very much.
Thank you.
Just sorry, one thing to add. I think we have another volunteer who was running late and who's again quite asset for us. Rehan Shajar, please, on the stage, please. And Qasim, I will hand over to you to start the session, but before that, I will ask my colleague, Dr. Sarmeen Muzaffar, to say a few words about APPNE Youth Forum. Qasim.
Thank you so much. So the idea, as like already Dr. Amir Khan has said, is what we would like a youth to participate and to get involved, any activities you all like to, for us to arrange, you can arrange yourselves too. So it's more the participation, and that will give you more like working together as a team. Then again, you are bringing forward, if there is anything, we all seniors are there, so we are there to help. And if do you require any support at any point? Even like you're coming up with the ideas where you're working or from the medical school and you think, oh yes, that's what we can do. Or like even like an educational session, any sports activities or any other ideas you have, we leave it to you guys to come forward, decide, put your names forward. You can email us as well if you like to participate and send us our ideas. Thank you.
Thank you, Samreen. As you guys can clearly see that our APPNE Youth Forum is clearly belong to medical student at the moment. They're all volunteer, they're all at the medical student, but they are the future of APPNE. On this note, I will actually ask Dr. Qasim Sohail, who's a ST3 in orthopedic and trauma, to lead this session and come out with some bright ideas for us to take APPNE forward. Thank you, Qasim. Over to you.
Hi guys, thanks everyone for being here, and special thanks to everyone that presented today. All of you guys did a really, really great job. I'm sure it was really difficult for the people that were ultimately awarding the points to decide on a winner. As Uncle Habib mentioned, I am a trauma and orthopedic registrar, and I'm quite interested in the idea of all of this, the Youth Forum. I've been a member of APPNE now for 2 years, and I've been quite surprised. There's been a lot of educational activity, a lot sort of talking about some of our more senior members, but not a lot to engage our more junior members, and it's really encouraging to see that we've got medical students here as well. So I think this is a really, really worthwhile and really much needed initiative, which I'd be really, really keen to spearhead and get going. I mean, I think it might be a useful, actually, activity to start by asking the medical students that we have here what their thoughts are in terms of what they might need. Obviously, medical schools will give you some careers guidance and some pastoral care as regards like planning forwards from the point that you graduate. But is there anything that you guys had in mind at all that you think is sorely lacking from your experience as students?
I think the points on the slide up there are the main key areas that we want to target. We've split the roles up between us, so we can go down and introduce ourselves first, I think.
Okay.
Right.
Of course, yeah.
Okay, so I'm Lisa. I'm currently a third year at the University of Liverpool. I would like to take an active role in the social activities for the young student doctors and trainees in the Youth Forum. I think networking and building connections at an early stage in your medical career is very important to progress in the medical field. So.
I'm Zaina. I'm a fifth year at Nottingham, and I'm quite interested in that academic and research aspect of it. Like having my own publications as well. I help people work on their academic portfolio for their future applications.
My name's Shayan Sumro. I'm a foundation year 2 doctor at Sandwell and West Birmingham hospitals. I'm currently doing an academic job, so I feel like I can bring, a couple of things to the table, including mentorship, so applying specifically to academic jobs for foundation year. And with that includes, support and advice on, again, things like research, but also my keen interests are in ophthalmology as well. So providing teaching on certain specialties like ophthalmology, which are sort of less focused on an undergraduate teaching, and potentially run teaching sessions as well.
I'm Guzwan. I'm a first year medical student at King's College London. So having recently gone through the application process and A-levels itself, I think, I'd have a particular interest in facilitating facilitating prospective students in their application, and being able to disperse relevant resources and whatnot, and sort of at the foundation level also introduce representatives at various universities to sort of help build that community. As like Lisa said, the next generation, I guess. So I think, just helping these prospective students sort of through things like outreach programs and conferences like these. So, yeah.
Great, amazing. So, I mean, I'm really, really impressed once again that you guys have offered yourselves up so willingly to, yeah, absolutely, to each of these categories. Now that I'm so inspired by you guys, I'll probably suggest one. From my perspective, I'm an international medical graduate. I graduated from one of the universities in Europe, and I have had a bit of a difficult time making that transition from medical student to a Foundation 1 program. Thankfully, at the time that I graduated, it was easy enough to get into an FY program. Oh, yes, Ryan? You got to choose one. What's left?
My name's Rayan. I'm also an international medical graduate. I recently graduated in Romania, so
congratulations.
I feel like I can also offer the international experience and what it's like to try and integrate back into the NHS.
Brilliant. I think that's much, much needed. And obviously some of our APPNE members are making the transition from Pakistan to the UK, and I think they can use some careers guidance and counselling with regards to PLAB and other transitionary exams and forms and all that sort of stuff. But in addition to that, I mean, I've had the delight of going through the core surgical experience and the interview process that led up to it, and ultimately to the ST3 interview. I'd be more than happy to practice interview stuff, and this was one thing that I found. There is a lot of times, in my experience at least, like intimidation. Sometimes you feel a bit nervous to approach people that you work very closely with or people that know you personally. I think sometimes you feel a bit nervous that, oh no, what if I get judged by this person that's my mate that otherwise thinks I'm competent? What if I'm rubbish? And sometimes it's nice to have an outsider perspective and, you know, someone that doesn't work with you, know you super well, that can go through interview scenarios with you. And I'd be really, really keen to do something like that. Any other bright ideas, guys? Anything that we can do to make APPNE more than it is just now? Because obviously they're tackling lots of the really, really important stuff, the philanthropy, the service, obviously the social side of things. But is there anything that you guys think that we can innovate further with APPNE?
I think not only just restrict it to, you know, people from Pakistani backgrounds, but also increase access to other ethnicities as well. You know, just sort of broaden the horizons, make APPNE also a more, you know, popular amongst the general community. We don't want to single anyone out. You know, we can help everyone in the same way, in an equitable manner as well.
I think, Sean, you touch a quite important thing. As a APPNE executive and educational lead of APPNE, we are planning to do different educational activities across the region. We are in close collaboration with a BIDA, which is the British Indian Doctor Association, and also we are in close contact with a BAPU as well. And we are including other British Asian minor ethnicities because APPNE is for everyone, one community, one voice. But as Qasim mentioned, there's some of them, or most of them actually international medical graduates who came from Pakistan, and we're proud to say that all actually achieve whatever they deserve. And I think I'm extremely grateful to you guys. So I think, yeah, come with the bright ideas. I will catch up with you at the end for your ideas. I'll give it to Qasim then.
I mean, once more, if anyone has any other ideas, otherwise I'll probably leave the stage to you guys if that's okay. I mean, I think there's probably a fair bit of brainstorming that we need to do in private. Maybe we catch up at some point, do a video chat or something like that. But if we hit the ground running and target medical students, that would be a really, really good idea. I now hear that some of you guys are graduates now, which is awesome. And of course, if you're heading for ophthalmology, I'm sure you've got plenty of wisdom. That's a very, very streamlined application experience. I've heard it's incredibly competitive. So I think we've got aims at all levels, undergraduate, postgraduate, and you know, we've got lots of senior doctor members who I'm sure can be instrumental in helping us achieve our goals.
Thank you so much, Qasim. And once again, thank you to all the APPNE youth members. Please stay there. I'm going to ask any of the person in terms of, we have few postgraduate doctors who are in different career, different path of their career and different stages. As anyone would like to come and say a few words to motivate these young future doctors and to guide them and tell them that you are actually willing to do something for them, because as I said, APPNE Youth Forum is basically for A-level students, medical students, and foundation and year, like what you call as foundation year 1 and foundation year 2 trainees. But at the same time, we already actually conducting a mentorship workshops, career guidance thing, and please come forward and be part of APPNE. So anybody would like to say a few words? Please do. Dr. Faraj, Shajar, all the round applause for you.
Hello, everybody. I just want to address especially the youth here today and on all levels of their education. We came to this country 30 years ago, and the challenges we faced were very different and, in fact, quite phenomenal to what you guys are facing. In fact, due to the integration of the British system, things have improved a lot. And despite all the challenges we faced, we have made our targets, we achieved what we wanted to do. And because the grounds are so favorable for you guys, I think nothing is impossible. Whatever your goals, whatever your targets, whatever your dreams, if you put your efforts into it, I think you will achieve it, and it's nothing impossible. Somebody who can have all the adversities and faced the challenges can do so well. I think with you guys having less adversities to fight against, I'm sure you have your own problems, but comparing your generation before you, the problems they had, I think you are in a much favorable atmosphere, and I think you will achieve your dreams, your targets. So just keep your focus on what you want to do, and I can promise you that nothing is impossible.
Thank you so much for your wise words. I would like to ask Dr. Sawal Afzal, who is a pediatrician and our APPNE ex-executive member, and he's a life member. He's actively involved with APPNE, so he would like to say a few words for our youth. Thank you.
Just to add one thing, what my colleague has said about Dr. Afzal Sawal, I think he was the first person who actually created this pathway for education for all of you, and I'm following his path, and I'm really pleased to see and proud to say that he's here with us.
Yes. So nice. Yeah. So nice. Thank you very much. Thank you very much. Thanks for both of you for a nice introduction. I believe this, the APPNE Youth Forum is such a good initiative, which I thought we should have been taking a long time back, but you are the people who are the future of APPNE. I think these are all educational activity, but you can involve in more than these sort of activities for APPNEs, okay? Like fun activities and bring the life to APPNE, and rather than, okay, you're absolutely right, you're supporting your junior person, supporting the people who are coming and going to become doctors, but then again, more than this, come on, bring some more fun activities in the APPNEs, okay? Rather than sitting here look very serious, well, like, come on, let more smile and face things. I mean, I can give you the example of this. You know, the APPNE is one of the same organization working in the United States, and they have got the youth forum there. I mean, I have attended once or twice their function over there, and then the youth APPNE, the APPNE juniors, they do their own programs. They bring some more ideas, their own programs, and they run parallel to the parallel programs over there in the United States. And I think we can do same over here. So APPNE Youth, you have got all the support from all the senior people in APPNE whenever you need us. But on the other hand, so you need to be more versatile. Okay, education is one. So you can come up to bring the APPNEs a little bit more than that. Involve in different, facilitate them, becoming a membership, bring more members, do some more work, work for us, work for the APPNE things. But I believe you're the future, and you will, the future peoples will going to have all the support from all the people who are working on the background. But thank you very much. You volunteer yourself, and good luck with everything else. Thank you.
Thank you so much, Dr. Sawal. Once again, we actually managed to hear your kind words of wisdom. So I'm going to invite Dr. Ghayur Khalil, who is an IMT3 and associate college tutor at Kettering General Hospital. Gayur actually came forward recently with the ideas to help IMT, Internal Medicine Trainee Career Guidance Program on APPNE platform. And we are extremely pleased to announce the IMT Career Guidance Program in next few weeks, which is going to be supervised by Gayur Khalil with all the education team member of APPNE. And our president, Mr. Amir Khan, also spoke to Gayur last few weeks during our CME session on 30th of September, and he's very supportive of that. So please welcome Gayur Khalil.
Thank you very much for giving me the opportunity to talk today. I'm Gayur. I am one of the IMT3s in Kettering. I am also the associate college tutor, and I'll be representing APPNE in helping our international medical graduates from Pakistan who are working in the UK to get into training, into the IMT training. So we have a bunch of junior doctors who have agreed to provide such a platform for our junior doctors in the UK so that they can get into the IMT training. So we'll be running webinars, regular webinars, which will include how to actually prepare your portfolio so that you can get shortlisted into the IMT training. Then we'll be talking about the interview skills. Then once you get into IMT, how to actually manage all the 3 years, how to successfully complete your IMT training and to get maximum out of it. We'll be also helping out regarding the exams, which are very basic and which are the most important, I'll say, one of the most important part of the internal medicine training. So MRCP Part 1, Part 2, and PACES. So we'll be helping all the international medical graduates who work in the UK as far as internal medicine is concerned. And I hope I'll see you forward, inshallah, in future with my webinars. Thank you much.
Thank you so much, everyone, for your patience. On this remarks, I'm going to close this session. And once again, thank you to all of you for your patience and participating in poster competition and also be part of APPNE Youth Forum. If still you would like guys to participate or would like to involve in any educational activities, then please feel free to contact us. And our email address, which we're going to share with you guys on your email, but it's edu, which is short form for education, @appne.uk. Another is appne.education@gmail.com. So please feel free to be part of these educational activities. Once again, guys, thank you for joining us today.